So Eric, talk about the guidelines and that we have currently, and you probably should talk about how they're probably going to change a little bit.
Sure.
And this is for initial therapy. Let's talk about initial therapy first.
Yeah, we are really fortunate with HIV. It's how many large randomized control trials. I mean, we've talked about, when to start. I mean, we have several large randomized control trials. We talked about treatment during acute OIs. We have those. We just have a lot to work with, and we certainly do as far as defining the optimal therapy as well. And we basically have a variety of options, and they're mostly the guidelines panels are focusing on efficacy, and frankly the bar is so high now, if it's not highly efficacious, it's not going to be a recommended option, so it's almost a given. And then it's convenience and tolerability and maybe some other select factors of the drug like barrier to resistance. And the guidelines have evolved from a time where, from triple therapy regimens with non-nukes being the preferred options to non-nukes and boosted PIs with maybe some integrase when they were new, to now all integrase. Right. And at least in the US, the major guidelines, the DHHS and ISUSA guidelines are now saying the option for most people should be an integrase-based regimen. And it's either a raltegravir-based, which is now available for first-line therapy as a once-a-day option, although it's 2 pills and there's no single tablet regimen, or elvitegravir, cobicistat-based single tablet regimen, or dolutegravir, either as a single tablet with abacavir 3TC or with tenofovir FTC. So it's gotten really simple, and it's because all of those regimens have been demonstrated in randomized controlled trials to be highly efficacious and at least as well tolerated, and certainly variable levels of convenience, but mostly 1 pill a day type options.
Sure.
And those are the options, and I think we look at the comorbidities, we look at hepatitis B to see whether the person needs to be on tenofovir versus abacavir being an option. And then the other sort of branch point, I think, has traditionally been that population of people at high risk for poor adherence. And the guidelines have always sort of talked about that group and traditionally have said that that's a group perhaps where a boosted PI has advantages because they're at low risk for developing much resistance if they don't take their meds consistently. And now dolutegravir, based on now years and years of experience and clinical trials and in clinical practice and the lack of emergent resistance, I think dolutegravir has sort of now risen to the level of where boosted PIs have been for that select patient population. And those are the sort of the main areas. And then we have new and evolving options.
Sure.
And we had a new non-boosted integrase inhibitor that comes as a single tablet regimen of bictegravir with FTC TAF that was approved in the last week.
Yeah.
And it's based on 2 large randomized controlled trials in naive patients, comparing it with dolutegravir, abacavir 3TC, or dolutegravir TAF FTC. And then there's one big switch study. Yep. Where people were switched to it. And the bottom line is it showed similar efficacy in the head-to-head comparisons. It's very convenient. It doesn't have the problem with significant drug-drug interactions, and it was very well tolerated. So I think, we'll see what the guidelines panels do with it, but it's hard to imagine
I'm going to put Dan on the spot.
Good.
So Dan, your guidelines, now you're writing the guidelines now that this combination tablet, bictegravir, TAF, FTC is available. What's your recommended regimens?
Well, so let me just caveat by saying I was on the guidelines panel. I am not currently,
right.
so I'm not speaking on behalf of a panel.
Good.
But with that disclaimer, I think it's hard to come up with a reason why you wouldn't want to consider bictegravir, FTC, and tenofovir as a first-line regimen, as the initial choice, because as Eric was highlighting, there are really no significant drug-drug interactions to worry about as long as the patient's not on rifampin, and that's not a big issue in the United States. It's a huge issue in the rest of the world. You give it once a day. It's a single tablet. You don't have to do pre-screening for potential risk of hypersensitivity with abacavir. So I think it really does become the de facto go-to regimen for most people. I think it's worth just taking 1 second to point out when we say highly efficacious, what we mean is in the trials at least 90 to 95% of people in the study going on any of these regimens have achieved complete viral suppression and sustained that out to 48 to 96 weeks.
And the 5 to 8% that don't, most of those are people that just went off the study for some reason
Right,
or another.
right,
I mean,
right.
the virologic failure rates are more like 1 and 2%.
Exactly,
So that, I think, is critical.
And the one thing with bictegravir that I think is going to need to play out, because it looks a lot like dolutegravir, right? It's a non-boosted integrase that's available as a single tablet regimen. I think the big difference right now is, although in the naive trials that have been conducted so far, none of the patients have developed any resistance to integrase or nukes, much like what we've seen now with all the dolutegravir experience. And there's reason to believe bictegravir may also have a higher barrier to resistance like dolutegravir. We clearly don't have as much data yet to tell us that we can think of it like dolutegravir for that high-risk population.